Thank you everyone for joining tonight's webinar with Dr. Pamela Smith. Tonight we will highlight female health issues related to advanced endocrine therapies and upcoming educational opportunities to further your expertise in advanced endocrinology and compounded prescription. Dr. Pamela Smith is a diplomat of the board of the Anti-Aging Academy of Anti-Aging Physicians and is an internationally known speaker and author on the subject of metabolic, anti-aging, and functional medicine. She also holds a master's in public health degree along with a master's degree in metabolic and nutritional medicine. Dr. Smith is currently the director of the Center for Healthy Living and Longevity and the founder and chairperson of the Fellowship in Metabolic and Nutritional Medicine. Dr. Smith is also co-director of the Master's Program in Metabolic and Nutritional Medicine at the Morsani College of Medicine at the University of South Florida. Due to the very high attendance this evening, please submit your questions by using the chat option, and we will address a few questions at the end of the webinar. Dr. Smith, I will turn the webinar over to you.
Thank you so much, Lindsay. Good evening, everyone. We're going to spend a few minutes tonight looking at a common female problem, vaginal dryness. And there are some references for tonight. Vaginal dryness is the reduction of lubrication of the luminal surface of the vagina. Can occur at any age. Can occur due to low estrogen. Sometimes it occurs due to birth control pills or oral contraceptives, because when we give people oral contraceptives, we're commonly giving estrogen in them, and sometimes the body shuts down or at least decreases the feedback mechanism of its own loop in providing estrogen. And sometimes at perimenopause, we end up with vaginal dryness before we end up with actual estrogen loss, and then of course menopause. Vaginal dryness occurs in 14 to 31% of the population of all women. I actually think this number is probably higher than what is being reported in the study below. It occurs in about 50% of postmenopausal women. 63% of women with breast cancer have vaginal dryness. So two types. There's simple and there's complex. The simple is related really to the vaginal neurovasculature, and as we keep everything hydrated with estrogen, etc., then we get a resolution of the symptoms. In a complex form, it's really multifactorial. So vaginal dryness more common in diabetes, hypertension. Patients would have vaginal atrophy for a number of reasons, and patients with high-tone pelvic floor dysfunction. The resolution of the dryness may not resolve the symptoms, however, in some patients. Now, there is vaginal atrophy, also called atrophic vaginitis. This is an inflammatory condition of the vagina and outer urinary tract, and it's associated with thinning and shrinkage of the tissue. Also associated with decreased lubrication, and this occurs in about 43% of postmenopausal women in the U.S., but the rate varies in other countries. And then there's how the diagnosis is made. Differential diagnosis is here. So we can look at vaginal lubrication. This is made up of ultrafiltered blood, so it relies on a healthy blood flow to the area. There's really no glands in the vaginal area, and blood pressure does push fluid from the capillaries through intracellular junctions between vaginal epithelial cells. The resultant vaginal transudate is composed of water and very small proteins that combine at the vaginal surface along with dead epithelial cells. And then, of course, there needs to be sufficient nitric oxide because that causes vasodilatation. So vaginal lubrication is very dependent on the availability of nitric oxide. And this enzymatic activity of NO synthase is increased by estrogen and other sex hormones. So in other words, nitric oxide by itself is not enough for the effect. There's many mechanisms that can suppress the production of nitric oxide, so it's very important that the levels are normal. Too high is not good, too low is not good. So if you have too much nitric oxide, you end up with an inflammatory component, and this can lead to free radical production. Low inflammation supports the bioavailability of nitric oxide in aiding lubrication. And of course, different ways we talk about a lot in the fellowship and master's program and in the certifications are manipulation of nitric oxide production. So you have to have sufficient L-arginine from the diet, and here's some foods here, and enough calcium in the diet. And then, of course, facilitation of the activity of nitric oxide synthase does require hormonal balance. It does require medications and supplements such as niacin, angiotensin-converting enzyme inhibitors, angiotensin II receptor blockers, ginseng can all function to manipulate positively nitric oxide. And then, of course, a reduction of hyperglycemia can be helpful as well. Other ways to manipulate prolonged activity of nitric oxide and cyclic guanosine monophosphate. In other words, we can use phosphodiesterase 5 inhibitors. And then, of course, the bioactivity of nitric oxide. Aspirin, vitamin D, decreases inducible nitric oxide synthetase. In ginkgo, decreases inducible nitric oxide synthase and is a nitric oxide scavenger. Red wine, plant polysterols, and, of course, flavonoids. Other, moderate exercise on a regular basis. So, what are some risk factors for vaginal dryness? Well, certainly decrease estrogen from any of these reasons. And then other risk factors for vaginal dryness, other medical conditions that are listed here on the slide. And then these prescription medications. Note that antihistamines and decongestants are on here. Something we may not think a lot about, antidepressants, and then of course any anti-estrogen therapies, diuretics, and then progesterone predominant oral contraceptives can be a risk factor as well. Unwise behaviors. A lot of douching can cause a problem, highly absorptive tampons, lack of sufficient arousal before intercourse, male condoms that don't have external lubricant can be a problem, very hot baths, strong detergents, hydrating soaps, and then, believe it or not, alcohol can be a dehydrating factor. So, having said all this, what are some metabolic therapies that we can do tomorrow for vaginal dryness? Well, certainly topical vaginal lubricants that are water-based can increase moisture, like KY jelly. You want to increase moisture, but if they have a high pH, they can also dehydrate. So KY is probably not the best, but it is one that is commonly used. It would be better if we use something with a lower pH. There's polymer-based lubricants, there's silicone-based, there's oil-based. Oil-based can seal in the moisture, but it may be hard to remove from the skin. The type of oil does make a difference. There's petroleum-based, which are strong solvents, and they can actually dissolve latex, so not suggested. Oils that contain fatty acids like olive, avocado, coconut are weaker solvents and do not degrade latex. Olive oil can be a problem sometimes because it can become rancid. Avocado can stain the sheets green, and then coconut is hard to clear the vaginal lumen with long-term use. So we're just going over the different topical vaginal lubricants. Then there's liquid silk lubricants that have both a water-based and moisture-based sealing. They're made with propylene glycol and parabens. For some people, this can be irritating to the skin. You do have to massage it into the vulva and vaginal area, PRN, up to TID. can be very useful for lichen sclerosis and psoriasis. Then there's pink silicone lubricants, more useful as moisture sealers than moisturizers. And the pH here is more acidic, and for some people that can be a problem because they might get more irritated. Then there's the liquid organic silk lubricants. And these can be massaged into the vulva and vaginal area, PRN, up to TID. Some of these contain aloe that can be irritating to some women. And then sometimes the preservatives can be a problem, and these can be water-based with silicone. Then there's what I lovingly call the vaginal renewal program. This helps patients recondition the health and flexibility of the skin of the vulva and the vagina by increasing blood flow through dilatation. It reduces friction, tearing of the skin. It increases blood flow to the vulva and vaginal canal, and very helpful for the women that are listed there. Can use with topical estrogen, which may be more effective than estrogen or the vaginal renewal program by itself. And then pelvic floor muscles are not flexible, then obviously you can send the patient to a physical therapist that specializes in pelvic conditioning to help for vaginal dryness. If the patient has vaginismus, then the vaginal renewal program is counterindicated. Smoking can cause changes in endothelial health that can enhance oxidative stresses. So smoking is a risk factor, so obviously we want to get the patients not to smoke. Having a good exercise program affects nitric oxide positively, and it improves lubrication if the patient exercises before intercourse. Other metabolic therapies, diet, eating a Mediterranean diet can be very helpful because it decreases inflammation. Nutrients, botanicals, and medications we're going to look at. So let's start with vitamin D. It has a very important role in assisting dietary calcium, and it elevates the bioavailability of nitric oxide after production. And then we've talked many times about there's a certain number of people with active cancer, people with hyperparathyroidism, people with granulomatous diseases like sarcoid, TB, and Crohn's. You cannot give a lot of vitamin D to because calcium can increase. Another nutrient, omega-3 fatty acids, can be very helpful. Helps to absorb vitamin D, decreases inflammation, and acts as a lipid-based antioxidant. If you go above 3,000 milligrams, it can be a blood thinner, so you don't want to use it with other blood thinners. Calcium citrate, need extracellular calcium for nitric oxide production. And then, of course, niacin helps reverse endothelial dysfunction. Of course, people can get a niacin flush, so they may need to take an aspirin ahead of time. At first, niacin can exacerbate vulvar dermatoses due to recoupling of nitric oxide production, which causes temporary inflammation, but that resolves right away. Now, of course, L-arginine acts as a protein substrate, and we don't want to give L-arginine, though, to people who have, for example, a valvular problem of the heart, like aortic stenosis, because we don't want to increase nitric oxide in those people. L-arginine increases nitric oxide production, but we don't want to increase nitric oxide in people who have valve issues because it might put too much of a strain on the heart. There are botanicals for vaginal dryness that support tissue integrity, epithelial thickness, moisture, and tone. These are phytoestrogen-like effects. These soothe, moisten, and heal. And then ginkgo, we discussed. Ginseng does facilitate endothelial nitric oxide release. Alfalfa is a nice phytoestrogen, may have beneficial effects on estrogen, and it has been suggested for vaginal dryness. Calendula, as a cream, can be applied BID. It soothes the vaginal tissue. It helps minor abrasions, and it may have an antibacterial and antiviral effect. It's suggested by the German Commission E for skin and mucosal injuries and abrasions. Hops has estrogenic effects, since it contains 8-prenylnaringenin. It also has strong estrogen receptor binding bioactivity. Hops help with vaginal dryness. They may also help with hot flashes and night sweats, may decrease insomnia. May interfere with barbs, so barbiturates can be a problem. Hops and they do not tend to mix. And then sometimes hops can exacerbate depression. Red clover contains phytoestrogens. It may help with vaginal dryness and may help with other menopausal symptoms. And there's a case report that Panax ginseng was helpful. It was given transdermally. Comfrey is another botanical that moistens, heals, and soothes irritated and inflamed tissues. Some of the components have an anti-inflammatory activity and tissue healing. It can be used as a vaginal salve. Comfrey oil has been shown to increase epithelial cell growth and tissue integrity. And the German Commission E does approve topical use only on unbroken tissue. Black cohosh orally has not worked for vaginal dryness, so don't try this one. Topical ginseng has not worked either, so would not do that one. Tonera diffusa blocks progesterone receptors without receptor activation. It may boost estrogen, but really not recommended for vaginal dryness. And then, of course, medications. Natural prescription hormone replacement, estrogen transdermally, fabulous. Absolutely fabulous. It helps maintain muscle tone of the vagina and urethra, which reduces vaginal irritation. It prevents drying and thinning of the vaginal tissues and improves symptoms that are already present. It can also be found to be very helpful as estriol, and that's really what we suggest is estriol. Estriol can be prescribed as 1 to 2 milligrams, inserted vaginally as a cream or suppository. I usually let the patient choose, and I usually start with 1 milligram. It can be inserted nightly for 2 weeks, then Monday and Thursday for 2 weeks, and then PRN. And this is really my go-to. It is important what base you put the estriol in. I put mine in 50% Versa base, that's VERSABASE, and 50% Mucolox, MUCOLOX, Mucolox. So 50% Versa base and 50% Mucolox. The Mucolox is a new base, and what this base does is it has a really nice effect because it holds the medication in the vaginal vault longer. You can compound progesterone PO. It can be helpful to the bladder, so sometimes that can be part of the problem. You can compound DHEA and testosterone vaginally, but I'd like to recommend starting with E3 estrogen first. And then, of course, 5-phosphodiesterase 5 inhibitors reduce insulin resistance in endothelial capillaries, and they prolong vasodilatation, which has a good effect on genital perfusion. Possible side effects of phosphodiesterase 5 inhibitors. Oral form is not recommended for vaginal dryness. Hyaluronic acid can be used. I didn't put that on the slide, but for patients who don't have resolution with hormones or women who have a problem with breast cancer or other hormonally related cancer where they can't use estriol, then you can use hyaluronic acid. And what I'll do is I'll send out a formula to everybody tomorrow for hyaluronic acid. That would be a nice addition to what we could do here. So this seminar is actually part of Module 1C on women. Module 1C is part of the Advanced Endocrinology certification at the Morsani College of Medicine at the University of South Florida. I really do recommend that everybody get the certification. This Module 1A is Module 1, and many of you have already taken Module 1. This is the only course where we teach bioidentical hormones in a medical school. So I'm getting this certification myself right now so that if I ever have problems with other doctors asking about my credentialing, because I'm an internist and not a GYN, I'm getting this credential. In case the medical boards ever want to know why I'm prescribing bioidentical hormones, I can refer them to the fact that I took this course at the Morsani College of Medicine. Also, for those GYNs out there, Course D, that one is on men and methylation. So it's a great advanced course for people to take if you aren't used to seeing males, where you can look at men's health. So course 1A is module 1. Course 1B covers many endocrinopathies such as hyperparathyroidism, hypothyroidism, hyperthyroidism, and difficult patients to give hormones to. 1C is women's hormones and looking at breast health and all kinds of things that you can do for women that are not related to hormones. And then 1D is men's health and methylation. You can take all of this online, but I'd love to invite you all to join me for Module 1C, which is being given October 22nd through 24 in Boca Raton, Florida. It's great to see you guys in person, so you can take it online, but I'd love to see a lot of you there. It's Module 1C, October 22nd through 24 at Boca Raton, Florida. It is at the Marriott, which is a fabulous property, a lot of great restaurants around it, wonderful fun places to eat. My personal favorite is Rocco Tacos, where they literally make the best tableside guacamole anywhere in the world. It's fabulous. If you're interested in hormones, we are running a combined session with PCCA and MMI in Vancouver. That's November 19th through 21, and we're going to be looking at a lot of interesting things, including the idea that we're going to look at some hormone protocols. So would love to see you also in Vancouver, which beside Paris happens to be my favorite city on earth. Love Vancouver, November 19th through 21. Either one of these, contact your A4M representative. If you don't have one, then please contact me personally at faafm63@yahoo.com. That's faafm63@yahoo.com, and I will be happy to refer you to an A4M MMI representative. Also, do be aware that on December the 10th, I will personally be running a workshop with Dr. Sahar Swadan on how to dose hormones as a protocol. For those of you who know me, know that I've always said I would never do a protocol, but guess what? I've now looked at 20,000 saliva tests and have developed a protocol for dosing. So we'll be presenting an all-day seminar. It's a workshop, December 10th, before the A4M conference and before the modules. I encourage you to be involved. Please contact your MMI representative. What questions do we have, Lindsay?
Dr. Smith, we don't have any questions at this time. However, if anyone does have a question, please feel free to email that right on over to us, and Dr. Smith will address that. So thank you so much, Dr. Smith. We wanted to thank everyone for their time, especially you. We hope that you have enjoyed the webinar. If you do have any questions on the advanced education, we would love to answer your questions and support you. Our direct line is 561-910-4960.